What are we collecting data for? Are we collecting data to justify the funding? Are we collating the data because it's a study of us? Are we being studied?
Hi and welcome to today's Roundtable event. Today we're bringing community leaders who work in mental health together for vital conversations which we hope will not only provide education and awareness of mental health within the community, but will also go towards advocating for systems change. We really hope you like it.
How can public health and mental health services use an intersectional approach, considering race, gender, and socioeconomic status to improve investigations, address hidden risks, and develop a more equitable and effective prevention for Black and global majority communities? Okay, what a question. I think when it comes to, the first point from the statement about suicidality and the lack of also deaths being recorded, but I think just the lack of data when it sometimes comes to suicidality and how it affects the global majority is something we have to look at. I think when you're looking at a systemic level, suicide rates are the highest they have been in 30 years, and it's even more inequitable for Black and global majority people because the system is not designed for them. I think when we're looking at the way that people are falling in between the cracks of care, there's gaps in the care system for those that have attempted suicide. There seems to be sometimes a binary way of looking at someone who's at the beginning of a crisis and unfortunately bereavement. But when we look at the middle of that, and I think where body and soul sits, and those people that have attempted suicide, we see an exponential number of Black and global majority people because they are the ones that are falling between the cracks. They're the ones that are not known to NHS systems, they're not known to any other kind of third sector systems either. So the question, I think, of how we can ensure equitability and look at intersections, it also comes down to looking at complexity of trauma. I think that when we're not looking at how trauma has an effect on individuals, and especially of the global majority, we're not able to ensure that healthcare is there for them in the centralised healthcare system. I think I'm making more statements than an answer, but I think it's something that can't have an answer within a couple of minutes. But I think what we do know that we're doing at Body and Soul is that you're using a revolutionary way of working when it comes to suicidality, because it's not about the crisis, it's not about the intervention in between, it's about the whole person, it's about the community care, and it's about looking at the way that complex trauma has an effect on somebody. And I think when you look at somebody in just the one throw of you have a 3-month intervention and then you expect their life to make sense thereafter, it's impossible, especially when it's confounded with consistency of racialized trauma, systemic trauma. We have to be able to be there and support individuals for a lifelong course and not for a moment of intervention and then they're left to nothing. And I think that is what revolutionary healthcare is, and that's what global majority communities also need even more so, because the systems leave them behind at a higher rate. So when we speak to suicidality and how we can look at intersectionality within that, we need to look at the complexities, and we need to look at why we are an organisation that sees those that are not seen anywhere else. And I think it's because we're not afraid of the complexity and we're not afraid of the risk, but we also have to take the risk because the systems are leaving people behind.
Yes, ma'am. Absolutely. And I think your point of the risk in and of itself is the thing that most organisations are quite averse to, right? You would talk to risk-averse, to try to mitigate risk, whereas actually when we're looking at suicidality, that's the risk. And we're talking about suicide prevention work, which is very different, the run-up to meeting somebody after an attempt, which then becomes complex mental health needs, is something that I find is not very readily available in systems. It seems to be the extreme of mental health care. We often talk about what does crisis look like? Crisis looks like a lot of different things to a lot of different people, and how do you measure what crisis is? So yeah, it's a really difficult challenge, I guess, to have, and that's why I love what your organisation does, because it's not afraid to look at the complexities around the human experience, especially when somebody has reached a point where they have attempted to take their life. So yeah, and especially for our community as well, there's certain challenges within our own community, not talking about it, which is why sometimes those numbers aren't seen. You know, they don't want it to be listed for religious reasons, all sorts of things. And I think the understanding within our own communities as well, there's a lot of work to be done there so that we can collect the information. But going back to your point about the data, you know, to what end? Is that so that we can have internal discussions amongst our community, or to ally to some request for a census document that looks at that, right? So, yeah.
I agree with you. I'm sorry. In terms of a lot of organizations just working in a very much risk-averse, you know, type of approach, because if then the worst happens whilst we're working with this person, you know, reputation of risk, this and that, we haven't done our job, but then it's having a full understanding of, you know, when someone is in crisis, you know, what actually happens, and having a full understanding of what suicide or ideation or any of the sort is, in the sense of who has responsibility. Ultimately, as an individual, if I decide to do that, then that's my choice. It's not about the people that I'm working with. I think was one of the biggest lessons that I ever learned when I started training as a therapist, that you have got no control over it. However, it's now about reporting and talking about these things so that we can start to work on how do we prevent it, because if that data is not coming through, then we are always going to be going round and round in circles. I think in the last few years, if you look at the data as well, we've got younger people actually committing suicide, and are these things being recorded? Because if they're not being recorded, it's going to keep on happening until at some point, oh yes, in this year, we're this number, why didn't we talk about it? Why didn't we put things in place? So very, very much important to, again, as a community, as a society, to be fully educated, to talk about these things and not be afraid of, you know, that data reporting these things, because it paints a picture, you know, rather than us just navigating without having a full understanding of what is actually going on.
I agree with your point about reporting and maybe the stigma that's in the Black community. I do think, though, there is a responsibility on every public health in every area to go about finding out what's happening in their community and look into that community and work out what they need to be looking at. And every public health organisation across the country has got a responsibility to create a suicide plan. We've got a responsibility as a Black community to know what that plan says, and to know if we're missing from that plan and what is going on in our respective areas, to make sure that there is support services for those people that live in that area, wherever they come from, whatever their faith background, to actually work with those things, but also to bring people together with different expertise, the lived experience, the services, crisis support, etc. Because until we do that, we're not really going to tackle this problem, because we need to understand it from that walk in my feet and be suicidal to what I didn't see as support services out there when I was feeling like that. I would say the only improvement that I've seen over the last 4 to 5 years that really has started to make a difference is that we're starting to use non-medical models for crisis support. So there are a lot of support services where you can walk on in there. Majority of people that work there will have lived experience of suicide, and I think people get heard better in those services. We minimise the risk in those services, and actually we should sometimes not be moving them on to the crisis services at the NHS, which rank their crisis. Yeah, I think those community services that are now in suicide prevention, they are really beneficial because they really hear the people and sometimes represent the community that they serve. And I say that because that's what our suicide service looks like in the evening. So I'm hoping that's replicated all over London and all over the country. I think we need to do that, and we need to get better at identifying who in this population is at risk based on data, but also talking to each other in our respective communities.
I think you made me think of something, when it comes to identifying who is at risk, I think something we see so much in our displaced community is how people speak to suicidality, the nuanced ways of which some people that are maybe more trusting of a system, they're able to say, that XYZ, I don't feel like I'm okay. But then when you look at the differences in language of the people expressing they are tired, people expressing they want to go back home to God, there are so many different ways of which we have, over the past 30 years, have had to identify when someone is actually feeling that way. And I think that comes, like you're saying, I think our community model helps with that, but the other interventions, if you're looking at someone that's struggling with housing, someone that's struggling with immigration, how are we picking up the conversations when people are saying that? And it also means that we need to know who is there in place to best support those individuals, what organisations are best in place to support that complexity of trauma and the complexity when it comes to navigating a system that so many people are actually not very trusting of. So I think when you speak about the way in which we can identify that for people, it's also not about what's wrong with you in a medicalised way, it's what's happened to you. And I think that question alone can allow people to bring forth exactly what's happening to them in a different way. So yeah. Okay.
That's a really good point. There's one thing that we always say: do not interpret what you think the person is saying. Really inquire. So somebody can say, "I'm tired." Don't assume that they're physically tired. So I'm tired can mean I'm just done with everything else. So just inquiring, and not put our own interpretation on it, sometimes opens up conversations into these things, and people can start talking about it, and interventions or support can be put in place. So very, very important, as you're saying.
Yeah, and I just wanted to pick up on the data that we do have around the risk factors for suicidality and suicide, which you touched on. Trauma, we know that disproportionately impacts Black and global majority communities. Poverty, such a big driver, debt, unemployment, all of these, like you were saying, we need that public health response to these drivers. But also when, if someone has made an attempt, how do we make sure there's that continued wraparound support around those things? Because, we're living through very challenging times. Lots of young people in particular feel this great sense of despair and lack of hope for their future. It's not rocket science what some of these factors are, and we know it. So
and we know that after you have a therapeutic intervention, it's the ebbs and flows of life are still going to be there for you. That's why it's important we always have that casework support, the advocacy support, the support around just the things that will happen in life. And I think, like you're saying, the data that we have if you're looking at long-term health conditions, for instance, like the members we support living with HIV, the rates of suicidality being so much higher. But then the question is, why are other organisations that work within those sectors also not looking at suicidality? And then it ends up being a bigger gap in the system. So I agree in the sense of the data is there. So how do we then use it to make sure we're implementing that consistent long-term care? Yeah.
Also, you touch on signposting. We've got 4 or 5 organisations in here that are doing the work. We're trying to set up a pathway of support at the moment and making sure you've got reputable organisations that are on the ground. We're a UK-based organisation, so we need everyone doing that work in different areas of the country. But knowing that you've got really strong partnerships with organisations that are in that space is also really key. And to your point, your programme around suicide being replicable, is it replicable? Has it been replicated? And can we get hold of them? Because something that Darlington and I look at is, okay, when somebody comes to our service and they'll say all of these things, I've lost my job, my partner's left me, I'm in a really difficult situation. And we go, 10 sessions of therapy. It's not necessarily that. What we're hearing, to Darlington's point, is, how are you feeling today, And they start to say, I'm tired, I've had enough, and picking up on those nuances and signposting them to a service that we know is near them and available, to them, so they can get the support that they need without saying the very word that comes up to them, because maybe that they haven't thought of it in that way. So it's about understanding the nuances and the complexities around language, to your point, but also how can we safely signpost people on, because it's not a service that we at Black Minds Matter UK offer. But we know that you guys do, and we now know that you guys do. So we need to make sure that and to Darlington's point is, no block door? No wrong door policy, that's it. So our no wrong door policy, that they come in, we safeguard them, and we signpost them on safely.
I think everything's language as well, you know. Because sometimes by default, you start replicating the language that has been filtered down. So in some respects, you may not want to think, 10 sessions, but that's how it comes out. That's how it comes out in the report, and that's how it comes out in your everyday, when really you mean something completely different. Yeah.